I'm Catherine Millington-Sanders. I'm a GP and RCGP and Marie Curie National End-of-Life Care Clinical Champion. In 2015, RCGP's National GP Survey confirmed 97% of GPs felt general practice plays a key role in the delivery of care to people approaching the end of life and those important to them. We know that our patients value the key relationship between them, their family, and their GP. This is particularly important when facing advanced serious illness and end-of-life care and bereavement. Serious illness and end-of-life care are an RCGP clinical priority. Total health and care spend for the last 12 months of life is estimated at 25% of total expenditure. With general practice facing increased pressures on workload and capacity, it is crucial that every practice is as prepared as possible to deliver well-planned end-of-life care to their population. There are over 500,000 deaths per annum. This figure is set to rise with an ageing population, and around 60% of these deaths are predictable, and therefore it's an opportunity for us to work in partnership with people to help plan their care better. Plus, an estimated 60 to 90% of people will have an informal caregiver in the last year of their life. Many of these may benefit from an offer of support from health and care services and also from connecting into supportive networks within their community. A great place to start is to have a look on the RCGP website at the Daffodil Standards page. The Daffodil Standards are the UK, RCGP and Marie Curie general practice standards for advanced serious illness and end-of-life care. There are 8 standards, offering a GP-relevant, self-assessed structure. All the resources are free and online to help you start. There is a blend of quality statements, evidence-based tools, reflective learning exercises, and quality improvement steps to help you assess your baseline practice, and whatever your starting point, to build on the good work you're doing already. Whether you select one or multiple standards to do over the year, the most important thing is to start somewhere. Each improvement step counts. Quality improvement doesn't have to be difficult or boring. It's small steps and changes that can result in significant improvements. When you sign up, you automatically have open access to all the resources and tools online, plus regular newsletters including information such as top tips, shared learning, blogs and more. You will also receive a welcome pack in the post, plus a sign that you can display in your practice as a mark of your commitment to improving care for people affected by advanced serious illness and end of life. The Institute for Healthcare Improvement's Model for Improvement suggests we need to answer 3 fundamental questions for any quality improvement project, and then use PDSA cycles to test change ideas. These 3 diagnostic questions are: 1. What are we trying to accomplish? 2. How will we know that a change is an improvement? 3. What changes can we make that will result in an improvement? More information can be found on the RCGP QI Ready website. Whatever your starting level, analysing your baseline data is key to assessing where you want to focus your improvement efforts and what impact your improvement is having. The Daffodil Standards Quality Improvement consider 3 main sources of baseline information. 1. Retrospective death audit. 2. Feedback from patients, caregivers and patient participation groups. 3. Feedback from practice staff and MDT staff. Remember, you don't need to collect data for the sake of it. Like a jigsaw puzzle, these different sources of information offer connecting perspectives that can help your practice build an understanding of your baseline performance across each Daffodil Standard and where to focus your improvement activity. Think about what's helpful for you to collect, how often, and how to incorporate data collection into your business as usual. You don't have to do it all at once. it's about building a picture of what the care offered from your practice is like, consistently and to all patients and caregivers affected by advanced serious illness and end of life. For example, using a simple audit template in your end-of-life care MDT, such as the one found on the RCGP Daffodil Standards website, will make it much easier to re-audit and reflect on all your deaths of patients you've discussed in your MDTs. Understanding the experience of care from patients and those important to them is crucial. If you're able to ask a range of people about their experience, it is possible to start to pick up common themes for improvement across end-of-life care. Whether you use a few set questions on a telephone call, or ask a questionnaire with patients and families, or you look to your patient participation group for more information, different methods can be used and practices can choose whichever is more feasible and relevant. One example of information collection may be during a follow-up telephone call, for example with a wife after her husband's died. This can be an opportunity to ask about their experience of care received from the practice. This could be as simple as explaining, as a practice, we look to continuously improve care to patients and those important to them. Can I ask you, 1. From our GP practice, what was most important to you and your husband when he was unwell? 2. What could the practice improve? And 3. What did you think the practice did well? This can help you collect common feedback themes to aid your quality improvement. Use different methods to interact with staff and find out what's important to them when looking after people and what their experience is of delivering care to people affected by advanced serious illness and end of life. Would they want to be a patient at your practice? If not, why not? Naturally, it's easier to hear positive feedback, but improvement tends to grow best when there's a balance of positive and negative feedback. So make it clear all views from members of the team are important, whether feedback is positive or negative. Try and avoid the urge to justify issues raised and use them as an opportunity to hear and get underneath challenges for staff and patients. Examples of seeking feedback can be an annual online survey with questions covering different aspects of delivering care, or a dedicated practice meeting, or using an anonymous comments box where any staff member can pop suggestions to help improve end-of-life care as they spring to mind. All of these can stimulate reflection and a non-blame discussions to help drive improvements. Here we will look in more detail on how your practice can approach the retrospective death audit to support whole practice learning in order to improve the experience of care and support for people affected by advanced serious illness and end of life. Step 1. Clarify who your end-of-life care named leads, clinical and non-clinical, for the practice. They can help support a culture of reflective learning and improvement, enabling reflective discussion with the practice team and supporting change ideas to thrive. Leads are not there to do everything, it's the whole team approach that's important. Step 2. Communicate and share the ambition to improve the experience of end-of-life care for all patients and those important to them. If people are not aware, they can't contribute towards the vision for the practice. Step 3. Consider any learning needs across the team to support these improvements. Step 4. Start your retrospective death audit. Run a quick search of approximately the last 20 deaths and fill in your audit template. Remember, it's not just cancer deaths or deaths of people on your supportive palliative care register. Consider care not only in the last few weeks or months, but also in the last years of life, when planning care and support is helpful to the patient and those important to them. The majority of audit measures are routinely coded, but a few, such as information documented within personalised care and support plans, may benefit from review of the clinical notes. Depending on your practice coding system, collecting information can take around 1 hour. To diagnose where to start your improvement activity, your initial audit template offers an opportunity to assess measures across the Daffodil Standards domains. There's an example audit template on the RCGP Daffodil Standards website. Consider your practice processes as you collect information across each column of your audit template. It's helpful to review how consistently information is coded. A simple test can be to ask different staff members, how do you code for end-of-life care plan discussions? Also, where do you input and view this information? For example, is it in your consultation or is it on a problem list? If important information is coded in different ways and staff don't know where to look consistently for this, it can inadvertently result in variation of care experienced. As you consider what's important to audit in your practice, you can also think through the processes needed to support regular audits. For example, which codes you want to routinely use as a practice to monitor. This process also helps all staff know exactly where to look for information, particularly when looking for information or making a decision in an emergency. Step 5. Collate your results for all 20 patients. For example, 15 out of 20 people who died had an expected or predictable death. 6 out of 20 people who died were on the palliative care register. 4 out of 20 people who died had a caregiver and next of kin name and contact details recorded. 3 out of 20 people who died had a personalised care and support plan, etc. Once you've calculated your results for each column, triangulating with information you have gained from patient feedback and/or staff views to form your baseline picture. You can consider your results against the Daffodil Standards evidence-based self-assessment guidance found on the RCGP Daffodil Standards website. Reflect on your audit and feedback results. Not on your own, but utilise ideas and information from members of your team, GP and wider networks, including your patient participation groups. Now consider, what are you trying to accomplish? This needs to be specific and include by how much and by when. Review against the Daffodil Standard area you are looking to improve. Remember, you don't need to cover all the Daffodil Standards. You set your own pace in Year 1. Take a look at some examples for quality improvement SMART goals found on the RCGP Daffodil Standards website. Looking at your audit results, what do you think are the priorities for your practice to improve? What's feasible and relevant? Now, with your practice team, set your SMART goals across the Daffodil Standards you have selected. Here are some examples of SMART goals after looking at your baseline audit and feedback information. Daffodil Standard 1. Professional and competent staff. If you picked up from staff feedback or learning needs assessment, they're not confident dealing with some aspects of end-of-life care. A SMART goal may be initially to do a more detailed SWOT analysis, strengths, weaknesses, opportunities and threats of their learning needs in order to plan some supportive training. Daffodil Standard 2. Early identification. If from your audit you clarify, of the people who died, only 4 out of 20, or 20%, were on your supportive palliative care register, yet evidence shows a benchmark of around 60 to 75% of deaths are actually predictable. You may decide to set a SMART goal of 60% of people who die over the next 6 months will have been identified on the supportive palliative care register. It may also be helpful to work out, on average, how many people die each year and each month at your practice, and therefore, how many people you anticipate needing to identify month on month in order to reach your SMART goal. Daffodil Standard 3. Carer support. Improving carer support can be broadly considered under 3 key aims: identification of carers, assessment of needs, to enable support to the patient and also to directly support the carer. Then signposting or referring to achieve the support according to their individual needs. This is covered in more detail in the RCGP QI End-of-Life Care Carer module found on the RCGP Daffodil Standards website and at the end of this video. A starter SMART goal example includes: if your audit shows 8 out of 20 or 40% of people on your supportive palliative care register had an informal caregiver identified, yet evidence shows a benchmark of around 60 to 90% of people in the last year of life have an informal caregiver, you may decide to set a practice-relevant SMART goal of 60% over the next 6 months. Daffodil Standard 4 – Seamless Planned Coordinated Care. If from your audit you realise that coding could be more consistent for key items across your audit dataset. For example, people identified on your palliative care register with a personalised care and support plan are specifically coded and on the problem list for all staff to see in case of an emergency. You may decide to review your current coding and agree and share a list of future expected codes for all staff to use across key items, and do this within a month of reviewing your audit. This will have the advantage of making future monitoring easier too. Daffodil Standard 5 – Assess unique needs of the patient. If only 4 out of 20 or 20% of people on your supportive palliative care register had a personalised care and support plan, you may decide to set a SMART goal of 50% over the next 12 months. Daffodil Standard 6 – Quality Care During the Last Days of Life. Over 12 months increase from 10% to 50% of people who died on the supportive palliative care register, with key principles documented for care of the dying person. An example of 5 key principles of priorities for care of the dying person are included in the acronym CRISP: Communicate, Recognise, Involve, Support, Plan and Do. Daffodil Standard 7 – Care After Death. If only 2 out of 20 or 10% of informal caregivers were contacted to acknowledge their bereavement for all deaths including suicide and sudden deaths, you may decide to set a SMART goal of 70% over the next 12 months. Daffodil Standard 8 – General Practice as Hubs within Compassionate Communities. Over 12 months to support your practice understanding the experience of care achieved as part of your baseline data collection, you may decide to complete a staff end-of-life care experience survey and a minimum of 5 patient or caregiver end-of-life care experience interview discussions. Example templates can be found on the RCGP Daffodil Standards website. Depending on your reflection style, there are reflection exercises on the RCGP Daffodil Standards website that are relevant to each standard that can help plan your project. Step 6. Another helpful phase in quality improvement can be to look at why something isn't happening already. For example, if a high number of deaths are occurring in hospital for patients with COPD, then some kind of root cause analysis using a fishbone diagram or 5 whys can be used. Here is an example of a fishbone diagram. So next ask, how will we know that a change is an improvement? The RCGP and Marie Curie Daffodil Standards Death Audit Template offers an example of a dataset across all areas for continuous monitoring. Following your audit and other baseline information collected, you will have a good idea of the areas you want to improve across end-of-life care. Next, consider what you're going to measure so that you will know whether your ideas for change are working. As you clarify the data that would be helpful to monitor, also consider where the data will come from. You may find some data will be quicker and simple to monitor in-house, but it may be helpful to see if other data could be produced externally, at a GP network and commissioning-wide level. The latter offers the benefit of peer learning. However, external sources can sometimes be slower and may not be provided frequently enough, so important to balance these practicalities. It can be quick to make a change, but how do we know we are making things better and not worse? All too often, we can think things are better, but really we need some sort of measurement to demonstrate this. So consider now exactly what you will measure. It's important to remember you don't need to measure all the things you measured in the initial audit. Focus on what you're trying to change and improve, plus what you think may change as a consequence. Keep it as simple as possible. Consider your main outcome measure, for example, percentage of people dying who are on the supportive palliative care register. You could measure a connected process measure, such as number of patients reviewed for consideration for the supportive palliative care register. You may also want to consider balancing factors, such as the number of additional home visits each week. Balancing measures look at consequences which are often unintended but happen as a result of the change you make. These may also need mitigating actions. So what changes can we make that will result in an improvement? Step 7. You've done your baseline diagnostics and goal setting, so now generate your change ideas. How will you reach each SMART goal? Brainstorm your ideas. Include as many team members as possible in this process. Your receptionist, your district nurse or clinical pharmacist can offer different perspectives and ideas which you will never know about unless you ask them. Be as inclusive as possible. In your practice or PCN meeting, ask everyone to consider your SMART goal and write down on post-it notes specific changes they think could be tried to get you closer to that goal. Be as specific as possible with these ideas, one idea per post-it note. There are reflective exercises that can help your team generate ideas for each Daffodil standard on the RCGP website. Example change ideas could be 1. Asking practice team staff who may not typically be asked, such as receptionists, to highlight patients who they may think have end-of-life care needs and their caregivers, who may benefit by being identified and on the supportive palliative care register. 2. Benchmark end-of-life care coding habits of individual GPs in the practice on how and where people are identified on the primary medical care record. 3. Provide information to patients and caregivers who have been identified as someone who may benefit from additional support and care, plus what they can therefore expect from the practice. If you find you have lots of change ideas and don't want to lose sight of any of them, it may be worth constructing a driver diagram. The RCGP Quick Guide to Driver Diagrams is on the RCGP QI Ready website. So you now have answers to 3 questions. The first is answered by your SMART goals. This should say exactly what you're trying to accomplish, by how much and by when. The second question is answered by your measurements. What are you going to measure and how often? The third question, you now have themed ideas, which are changes that will aim to result in improvements. Once you have your pile of post-its with change ideas on, consider grouping them into themes and putting them onto a grid. Those that are high impact but easy to do are potentially a good place to start. You know your practice population best. Make sure any comparison takes into account your relevant GP demographics. Share your SMART goals with your local GP network and ask for a robust challenge to consider if your ambitions are feasible and relevant. Agree to bring these back and your learning at the next meeting. Step 8. Test your change ideas with your first PDSA cycle. In a PDSA cycle, you make a single change, plan the change, do the change, study the effects by making our measurements and reviewing the results, and then we act on what we find. Start small with changes, and where they make a positive change, then expand and embed them into business as usual. Otherwise, adapt and stop changes where needed. Looking at a PDSA cycle in more detail. Plan. Consider one change at a time. Look at how measurements will be done, how often, how to display data. Consider using the Daffodil Standards audit template in your MDT to help you consistently review and collect this data prospectively, making re-audit and learning from deaths easier going forwards. Collect frequent data. A snapshot is fine, for example, a sample of deaths each month looking at the measures you're looking to improve. Consider also if there are any issues you need to address or mitigate for. Do. Now make your change. Study. Plot your data on run charts using Excel to help you. For example, plot the number of people who die each month and who have been identified on the Supportive Palliative Care Register, and on a separate line of these people with an end-of-life care plan. Look for significant changes in the data. Are things better, worse, or the same? Do you need any other data to triangulate your audit data with, for example, staff feedback or patient feedback? And are there any unintended consequences? Act. If your change is resulting in aspired improvements towards your SMART goal, expand on it and embed it. If the change results in no improvement or unexpectedly makes an outcome worse, reflect as a team why and consider refining or stopping. Go back to the start of the PDSA cycle and plan your next change using another one of your change ideas. Continue to monitor until you are sure you've embedded change ideas and new processes into routine team practice. So how many PDSA cycles do you need? Well, quality improvement is never really done. Although we talk about projects, really it is a continuous process of reaching your SMART goal or an extended SMART goal. Then reaching an aspired steady state. So you move on to consider how you will sustain your improvements. Are there simple measures you can continue routinely checking? How often do you need to monitor this for? And moving forwards, what do you want to improve next? The process doesn't end there. Celebrate and share successes, challenges and learning. Whether your change is successful or not, we can all learn from each other's experiences, and this is an important part of the quality improvement process to remember. Consider Daffodil Standard 1, relevant learning needs for clinical and non-clinical staff, and using a SWOT analysis framework for discussion with staff about any training needs. Explore if these are common learning needs across general practice peer networks. Continue to encourage a no-blame, active learning culture. Keep up your momentum and learning. Re-audit and choose where you want to start next. Choose your next project and start the process again. There is a selection of RCGP, Marie Curie and other educational resources on the RCGP Daffodil Standards website. That's rcgp.org.uk/Daffodil Standards.